Thank you, everyone.
Okay, so now we're going to move on to Pam Maley from Bureau of Program Integrity. Yeah, your left.
Okay, good afternoon, everyone, and thank you, Jill, for inviting me to speak about program integrity. I've been talking quite a lot to a number of different groups and committees and associations, so I'm always glad to share about program integrity. I'm a registered nurse. I have been in this position since 2002, but I've worked in the Bureau since 1992. So I have a lot of experience here and a lot of experienced staff underneath me. So today I'm going to give you just a very quick overview of who BPI is, and that's Bureau of Program Integrity. We are under the Office of Administration and have 3 different divisions there. Talk a little bit about some really very pertinent rules and regulations. Go through our review process so you understand what we do with our provider and recipient and caregiver reviews, some of the administrative actions we can take, some federal audits that are occurring that you as providers may be contacted, and I want you to be aware of what that means and the participation that's expected from that point, and then end with some tips and references. And again, please feel free to submit any questions as I go along. So the Bureau of Program Integrity is really an enforcement agency, and like I said, we impose administrative sanctions. We are in the Code of Federal Regulations, federally mandated to have an agency to prevent, identify, and combat fraud, waste, and abuse within the Medicaid program. We monitor the provider's compliance with Medicaid rules and regulations, and we want to ensure that our recipients are receiving quality medically necessary services and that they're not abusing their benefits. I have about 34 registered nurses that report to 4 supervisors underneath me. Our total BPI staff is about 75 staff within 2 divisions. And then we have a 3rd division that's third-party liability, and that's another 3-hour discussion. So tend to just, put them aside. But for the program integrity staff, we do have board-certified physicians on staff that can also assist with the reviews. They're looking at quality of care, medical necessity, and health and safety issues that the nurses would forward to them. We have internal medicine, emergency room, physiatrist for rehab services, a surgeon, a dentist, a psychiatrist, and a pediatrician. So quite a varying group there. We also have pharmacists and certified professional coders, and some other areas there that are supportive and administrative assistance. I'm not going to read through these, but these are regulations or definitions that come from the federal regulations of fraud and abuse, and these are often confused. And I just want to point out that fraud is an intentional deception, that you're trying to get a benefit that you're not authorized to receive. And that benefit can be money, can be a service, whatever, but intent must be proved. And that's something that's frustrating for our office, that we get a number of allegations of fraud, but if we can't prove intent to our Attorney General's office, then it becomes a case of abuse and is an administrative sanction, not a conviction to pursue down that road with a criminal action. I listed some regulations here. The Code of Federal Regulations specifically has 2 parts that are related to program integrity and utilization control. I encourage you to read these if you have some time at some point. They're a little dry, but if you can look at those and appreciate that for everything that is outlined there, the state agency must have a policy process for that, and in an audit we have to show proof that we are following these. And that's really how I learned these so much in detail by having an audit years ago that actually went sentence by sentence. Where's your policy? Show us how you're enforcing this. Also, the state regulations, Chapter 1101 is the general provisions. There's a lot of information there, and that does apply to all providers. And then, of course, you have your provider type specific regulations. The provider handbooks and billing instructions are always important and are updated periodically. There is a regulation that you have to bill according to the instructions that are contained therein. So I encourage you to educate your staff, that is your office managers and building managers, that they can keep up to speed with those instructions that are there. And then Jill has mentioned the Health Choices, Community Health Choices website, where there are agreements and various other information about the programs. These agreements do give our Bureau authority to review managed care network providers. These agreements also require that the managed care plans have their own special investigation type unit where they can conduct reviews of their network providers and monitor for any recipient abuse. I listed a couple bulletins here with the website that you can look at them for further information, but these are ones that I typically share because they're very important for most all providers, except for the second one. But it's things that you should be doing and monitoring within your program and ensuring that you're complying with what's stated in these bulletins. The first one is the enrollment of ordering, referring, and prescribing providers. This is a provision from the Affordable Care Act and was effective in April of 2016. So all your practitioners that are working in the federally qualified health centers, all your home health providers must ensure that all the practitioners are MA enrolled before they can go into a managed care plan or work for others. We have found problems with this in that in group settings, one person is billing for everyone within the group and maybe 4 other practitioners that are not Medicaid enrolled. So in that case, we look at that. That is a misrepresentation of the actual rendering provider. We recover the money for that, and consequently, the practitioners are then enrolling.
There is a caveat to this requirement under the Community Health Choices program. Under the Managed Care Final Rule, under a managed care program, the provider does not have to be enrolled to order, refer, and prescribe. And the providers, the Medicare providers, in order to receive their cost sharing for Medicare covered services, do not have to be enrolled for the managed care plan to pay them that cost sharing.
Okay, right. Medicare does not have to be enrolled.
Right.
So your CHC's rule is different than Health Choices rule?
No, Health Choices, under the managed care program, under the managed care final rule, a provider that is not part of the managed care provider network does not have to be enrolled to order, refer, and prescribe. If they are part of the MCO's network, then they must be an enrolled provider. If they're rendering, they need to be enrolled.
So I miscommunicated that. Yes, I understand. Yes, I agree with what you're saying.
Yes.
Yeah.
So I just want to make sure that it's understood.
Yes.
If we get any follow-up questions, because I know that that's been a hot topic specifically under our program, because we have 94% that are dual eligibles, and they were concerned that they would have to switch their Medicare docs if they were not an MA enrolled provider.
Does not apply to Medicare.
Yes. If they are receiving services from a Medicare physician, and that physician then can bill the managed care organization for cost sharing up to the fee schedule, they do not have to be MA enrolled. That would not apply for all of our
And
they can prescribe services and not be enrolled. and the managed care organization
Right.
would be required to pass.
But they can't render the service, not be enrolled. It's refer, order, and prescribe.
Right.
Right, yeah. My example was rendering. They were
Okay.
rendering the service and were not MA enrolled and were billing under a primary physician who was rendering, who was enrolled.
Okay.
Yeah. So we're on safe path. Okay. The face-to-face requirement was effective also in 2016, that the physician must prescribe home health, DME supplies prior to the initial start of home health services, and they must be related to the primary reason that the recipient requires the home health service. This is a physician face-to-face encounter. However, it can be conducted by a non-physician practitioner, which they defined as a physician assistant, registered nurse practitioner, certified nurse midwife, and clinical nurse specialist. So the encounter can be performed by any of those above. However, the actual order has to be written by the physician. This is something that we're also monitoring within the department and can recover money if there is no documentation that the encounter was performed or that the physician actually ordered the service. This encounter must be done within 90 days prior or 30 days after the initiation of the home health services. The third bulletin is the implementation of criminal background checks. This is, again, an Affordable Care Act ruling, and this was effective in April of last year, that it assigned high-risk levels and is for newly enrolled DME, home health, and attendant care providers at the high-risk level. Upon revalidation, it can be lowered to a moderate risk level. And with this high-risk level, it involves fingerprint checking through the FBI and other background checks. And I just make you aware of this, that there is an additional level of scrutiny there with the new enrollment of those provider types. And then the fourth one is applicable for all providers to be screening their employees and contractors per the federal requirements. This was effective in August of 2011, and the screening should be done upon hiring and monthly thereafter. It involves checking state and federal databases, and if there are any catches, I'll call them, for someone who is listed on one of those databases and they're employed within your facility, that is something that should be reported to our Bureau immediately through a self-audit type process. And I share two examples with you that I did have a hospital that employed someone who was a nurse who had been precluded. So she was not practicing as a nurse. She was pushing the stretchers around. But she is still employed by a hospital that had a high Medicaid population. She did not self-disclose. And when they found it, once they started doing checks, they did report it to us, and we ended up recovering the cost of her salary and the cost of her benefits. Even though she was not doing direct patient care, she was still excluded from participating directly or indirectly in any state or federal program and receiving any monies through that source. The other example happened actually in an FQHC, where there was a pharmacist who was terminated, convicted and terminated. He went to work for the FQHC and also did not disclose that he was a data entry clerk. Once the FQHC again started checking, and this was probably about 2 years ago, they self-disclosed to the federal OIG and to us, and had to again pay back his salary and the cost of his benefits for over a year's period.
Because a couple of our health centers shared your term catches that they had and the penalties with years, we actually went through a due diligence process evaluating vendors that do this on a very methodical basis, and the board has recommended a provider of those services that many of our health centers are using.
Very good. Yeah, it's really for their protection too.
Right.
Okay, for the ordering practitioners, and this kind of goes off of what Virginia was talking about with, you know, when you're ordering things, you want to make sure that it's necessary, that you're not ordering something just because someone is encouraging you to sign this form and trying to talk you into ordering services that may not be necessary. And I just point these out so that you can be aware of regulatory compliance to ensure that you're following the regulations, but also that it would help with the home health providers or the waiver providers to ensure the recipients are receiving just what is medically necessary and appropriate services. So for the practitioners, you're required to adhere to licensing standards and basic standards of practice in the general regulations in providing any medical care and in ordering any services. Any treatment that you order, including drugs, is appropriate to the diagnosis. It must be based on the history and physical, and it is really vital that you document all of that. The medical necessity has to be documented, and the services, and this is one you can use, the services that you order cannot be in an amount that exceeds the recipient's needs or cannot be ordered solely for the recipient's convenience. There are also provider prohibited acts that can lead to really egregious practices and can end up in allegations of fraud that we would refer to the Medicaid fraud control section. And these are kind of the things that if you're ordering something that is not medically necessary and the waiver program is submitting claims for services, then you have to question, are they submitting a claim based on false information or a false order for something that is not medically necessary and does not benefit the recipient. It's really then false authorization for the service. And they should not be submitting any claims for services that are without a practitioner's order except in an extreme emergency. So the home health providers, they've been talked about already. I just want to point out with the home health agency, again, the home health services are recertified for every 60 days. This provider type must also be Medicare certified to be a participating Medicaid provider. It's been talked about with the waiver services, that is an authorization every year that they remain nursing facility eligible. And there's the two different models there, home modifications and the non-medical transportation that we review within our bureau. And then also the durable medical equipment and supplies. Many of those services are prior authorized, but there's also the requirement that there be a face-to-face encounter before those services are received. Now to go a little bit into some of our process, our nurses act as case coordinators. They start a case and finish the case. They identify a case for review looking at our fraud and abuse detection system, which can profile and do peer comparisons and uses a lot of different algorithms to provide reports for us. We, of course, receive complaints and tips through our website. We have a MA provider compliance hotline, which calls are received there, and they can be anonymous. We receive calls from neighbors, providers, friends, family, I did say providers, just a lot of different sources there. They come into that the one area and are triaged. Claims are pulled, and then the information is forwarded to the section supervisor for that provider type for review. We also receive a number of referrals. Our comptroller's office completes quarterly audits, and they're looking for edits that may not have been working or areas where a new edit may need to be put in place. We have our prior authorization area. Our policy area sends things to us when there are new program coverages and new codes that are going to be authorized so that we can review and monitor the billings on those subsequently. The MCOs are required by contract to advise us of their reviews and recoveries and to forward tips that they receive, because if it's one MCO may be seeing something, but what we can do in our bureau is look across all the MCOs to see the impact with that provider. And of course, law enforcement forwards things to us that they have deemed to be not criminal or not fraud in nature. So our review process begins with the claims review for the designated time period. We typically do targeted reviews through the processes that I just explained. We request and review the medical records, looking at the medical necessity, the appropriateness, the quality and quantity, and any other required documentation. We then have a two-step process to notify you, the providers, of any findings that we may have. We begin with a preliminary findings letter that includes the regulatory citations and the listing of claims that have been in violation. Upon receipt of this letter, there are options for the provider to submit additional information that may change our findings, and also to request a teleconference or a meeting if they wish to discuss the findings. There is also a contact person in this letter that you can call and ask any questions of. After any review, then we go to the second step where we're notifying the provider of the final findings. And with the final findings, there's the request for restitution, which can be done either through claim adjustments and voids or through payment by check. This letter also includes the right to appeal and gives you the instructions, and it asks for a corrective action plan. This is a written compliance tool that is used to hopefully improve processes and help you with your compliance plan to eliminate deficient processes in the future. Now, we have historically always been doing the retrospective fee-for-service reviews, but in the past couple of years, we have started doing managed care network provider reviews. With that, the process is just a little bit different. We receive a number of complaints and tips. Again, we also look at items that we've looked at in the fee-for-service program to look at as a managed care program. We're reviewing the encounters for the designated time period. We do internal vetting to look for past history and is there any case with federal or state law enforcement. We also check for the licensing backgrounds and any disciplinary actions. And then we send a letter to the managed care plans asking them for vetting items that we ask for background complaints, any cases they may have done, and we ask them to send us their claims that have been paid to that provider. We then review the claims and compare them to the encounters, and then request medical and physical records from the provider and review those for the compliance with the regulations. And then, like I explained under the fee-for-service process, there is a two-step letter process. Again, we call them the preliminary findings and the final findings. The difference here is that instead of sending them to the provider, we send them to the managed care plan with just a copy to the provider. What we do is we follow the money. So the department is paying the managed care plan. The managed care plan is paying the provider. So our recovery and notification goes to the managed care plan. We will recover from the managed care plan. The managed care plan then has the option to send a letter to the provider and recover for the regulatory violation. The managed care plan can appeal to the department upon final findings. The provider can appeal to the managed care plan upon final findings. For the results of our review, we're really hoping to protect the participant in the delivery of the healthcare services, ensuring quality, medically necessary, and appropriate services. One task that we've taken on this year is validating that the medical services were rendered by licensed, certified, or trained individuals. We've developed a process to receive a report from the Department of State monthly for any license suspensions or terminations. We bounce that against our active provider list and can take action to terminate that provider agreement and recover any monies that have been paid for services after they have lost their license. We're also validating the medical services I mentioned before with the home health service agencies needing to have Medicare certification. So we have a quarterly report run that captures Department of Health information for any Medicare certification that has ended, and then we can match that again against our active providers. We do recover the Medicaid overpayment and are required to return the federal share of those dollars. And I mentioned the corrective action plans. So additional actions that we take, we may find an issue and send the provider a letter asking that you conduct a self-audit to see if you can identify additional claims that may be in violation. And in that case, there is no penalty when you do a self-audit. There is just a dollar refund for the restitution, but no additional penalty for doing that. We refer issues of health, safety, quality to the Office of Long-Term Living for all these home health and waiver services. We feel that's really important, and with their regional offices, they can refer it to the areas for further review to ensure that services are being provided, that no one's being left without the services that they need. We refer our federal cases of allegations of fraud to Medicaid Fraud Control Section, which is within the Office of the Attorney General. We also have federal agencies that are very interested in, right now, physician cases is big. And then Department of State licensing that we will refer matters there for review. We can terminate a provider's agreement and preclude their participation in the managed care in the medical assistance program. This is for egregious violations, violations with the provider prohibited acts that I mentioned, fraud convictions, loss of licensure and certification, and also failure to pay restitution. I wanted to mention the recipient restriction program because this focuses on recipient abuse, and I think in the FQHCs you may see some of this, and I want you to be aware that there is such a program and can report to us of anything that you may see. This is a process in where recipient claims are reviewed in both fee-for-service and managed care. We're looking for misuse and abuse or defrauding of the program. This is usually through what we quote as doctor shopping or frequent ERs, flyers. They're receiving excessive services. They're not medically necessary. They may be sharing their card. They may be forging and altering prescriptions. We are very interested in receiving that, and we do get a lot of referrals from pharmacists and physicians just of the prescription issue with forging and altering prescriptions. We do ask the physician to put in writing for us that he did not order this prescription, did not order this drug, did not order this quantity, has never been his patient. With that, we impose a restriction. What the restriction means is that in the promise payment system, and if applicable, it's the managed care payment system, their medical card is restricted to the use of one pharmacy, one physician, one hospital, if that's where the misuse has been through the emergency room. So it helps control a little bit and provides some medical management to steer them towards one provider for the services that they're needed. It's not always the true all. They can go out and pay cash, we find, and you know, that's off of the car, not using their medical cards, so we can't control that. But the recipient restriction is in place for 5 years. It's something that is a federal requirement that we can do, and all states have that. And I encourage you to report. I have reporting places at the end of the presentation. If you feel that there's anyone that may benefit from having some medical management and some restriction, at least in the payment of the card, that directs them to one physician. Restrictions are not applicable in the case of emergency services, so that is a federal requirement, and we have to restrict them to someone of their choice. Okay, for the CMS contractor reviews, there's two that I wanted to make you aware of. The first one is PERM, and you can imagine some of the pictures we put up about that. Payment error rate measurement. This is a joint effort between the state and CMS. They calculate a Medicaid improper payment. They look at recipient and provider eligibility for the date of the service. They look to see, did the claim process correctly on that date of service? And from the provider, they ask for the record to document and support the service on that date. This review is done on a 3-year rotation. CMS does 17 states per year, and Pennsylvania is now. So the providers, or the contractor, will be requesting records from the providers shortly, and the CMS vendor that is doing this is called CNI Advantage. Connie Nancy Indian, CNI. Don't believe CNI stands for anything, but just if you receive a phone call or a letter from them, please cooperate and comply by sending in the record. They usually only do a few claims. They don't pick a provider and ask for 50 claims. It's really very random, and only a few records from a provider. If the record is not received by the CNI Advantage contractor, it is an error for our state. And we're very happy that we have been below the national rate of errors. In 2015, which was our last review, the national rate for Medicaid errors was 5.7%. Pennsylvania was 3.2%. The other contractor review is called the UPIC, Unified Program Integrity Initiative. This is a CMS awarding contracts to vendors that are working in 5 different zones. Pennsylvania is part of the Northeast zone, along with 10 other states. The contract was signed in March of 2017. And what the UPIC is doing is simply performing PI functions much like our Bureau does. They will do data analytics, they will review, conduct audits, they can do on-site visits, they will do medical record reviews, and come up and determine violations that then the state can recover for. They do go through a vetting process with the state, and they have approvals for any provider type that they are beginning to review. Right now, they are reviewing non-emergency medical transportation, durable medical equipment, and laboratories, including orders, and then the subsequent claims that are submitted by the labs. Oh, and I did include a website there that there's additional information on our website if you'd like to read more about those 2 initiatives. So, some useful tips. You, the providers, can initiate self-audits. It's a voluntary review and disclosure of the overpayments that the department then validates, and again, there's no penalty as long as there is no fraudulent activity. We have what's called What's New on the DHS website. I encourage you to check this frequently. It includes new medical assistance bulletins, quick tips, and RA banners. We also have information about how to implement and monitor your corrective action plan on our website. And it seems every conference I go to, they talk about monitoring social media. Our recipients, participants, just put all kinds of things out there. They talk about sharing their cards. They talk about selling their DME supplies. It's really, they're selling their drugs. It's amazing. It's eye-opening. So I encourage you to have someone monitoring that also. Made a list here of where you can report fraud, waste, and abuse. The hotline comes directly into our office and is monitored by a person during the day. After that, messages can be left. We have the email, the fax, of course, mail, and there's a phone number to report any recipient abuse of medical services that you may find. I've included references, sites here for our DHS website. Jill went over the Health Choices, Community Health Choices website, which I agree was very easy to go through and a lot of great information there. And there's 2 websites listed for the Bureau of Program Integrity. The first one talks more about fraud and abuse. The second one talks more about our organization, the responsibilities of the 3 divisions, and our hotline. Listed there are contacts for the Bureau of Program Integrity. Karen Fickus is our Bureau Director. My name and phone number is there. I also included the 2 supervisors that report to me. Susan Troutman is a supervisor for the Home and Community-Based Services section, and Beverly Croft is the supervisor for all practitioner reviews and also for the recipient restriction program. And any questions? If we finish here, I guess they can come into
through
Sherry or Sherry, and okay, and be forwarded on to us. And I am known in the office for trivia or quotes or something like that. So my final slide is a thought for the day. And I did a conference recently in August in Texas, so I wanted to do Pennsylvania. So Pennsylvania has a Statue of Liberty out in the Susquehanna River. Pennsylvania has the Grand Canyon. Pennsylvania also has what is thought to be the first roller coaster. This was a mining car that was used, and the locals decided in the late 1800s they'd pay a nickel to be able to ride this and thought it was a lot of fun. So then my quote for the day, because you're at heights of everything, is when it all seems like an uphill struggle, just visualize the view from the top. Okay. Escape again. There we go.
So we'll just give it a minute for any additional questions. If you don't get your questions submitted today, you think about additional questions that you might have, please go to Sherry and Cheryl, and we will be glad to get any additional information back to you. And with that, do you want to close out with anything, Sherry?
Just thank you again, and we appreciate the partnership with all of you. You've been very responsive as issues have arisen in the Southwest. We very much appreciate that.
Great. Well, thank you so much. And again, we look forward to implementation in the Southeast. All right. Good afternoon, everyone.